Hi, everybody. I want to get us started off here. I know people are going to be sort of drifting in, finding themselves food. The only person who doesn't get to eat for the 15 minutes is our guest speaker. My name is Jürgen. I chair the Psychiatry here at the University of Washington, and it's a real honor to introduce speaker today. Dr. Joe Parks is a psychiatrist. He's also the director of Medicaid for the state of Missouri. Over the last 5 years or so, Joe has become a huge hero of mine because here's somebody who is a clinician who has figured out, in the world that we're in, which is sometimes a very beaten down world where we're all feeling completely overwhelmed and we feel like, how could we ever get from the state that we're in now to a better place? He has taken some wonderful initiative working in his state with the community health organizations in his state to really show us that, we can do different, we can do better, we can provide care where we're bringing the head and the body together. That's my setup. We're not very formal here, so I'm not going to say a lot of things about what's on your CV because I want people to hear from you. For those of you who have time, we'll have a time after this grand rounds for the next hour for you to stay here with us and ask Joe some questions so that we can use all the time we have to hear from him now. So I want to thank you for coming. It's a real honor, it's a privilege, and I really look forward to your presentation.
Thank you, Jürgen. It's a real honor to be here. We all talk nationally about what you've done with the impact model here in Washington, so I want to trade the information that I'm glad to hear you're inspired by what I'm doing, but we're watching you closely too, and I need to pick up some things that we'll talk about later on that. The one thing I did want to mention about my background is that I still see patients. I still see patients half a day. I currently see them in an FQHC, and that's informed a lot of my thinking about integration as having worked in both the CMHC university side and on the federally qualified healthcare primary care side. Jürgen didn't tell me I come with endorsements. He gave me nice endorsements, but it said that I'm not only dull myself, I'm the cause of dullness in others. You'll see in this presentation I use statistics like a drunken man uses lampposts for support rather than illumination. And you're about to experience me compressing the most words into the smallest idea of anybody you've ever seen. I'll be going over what is population health, then I'll be talking about what is population health management, why we need it in behavioral health care, and I may say a little about the psychiatric shortage, and then I'll give an example of the work we've done in Missouri. Basically, about how we can transform health, just in mental health, but in healthcare in general in the United States, basically operates like a cottage industry. We have individual artisans taking on tasks one at a time and doing whatever they think looks pretty or neat. And this has worked kind of okay for people that are basically healthy or acutely ill horribly for a limited time. But it has worked lousy for people that have multiple chronic illnesses over extended periods of time. The way most healthcare happens in this country is we wait for the patient to figure out that something's wrong with them. Once they figure that out, we wait for them to figure out who they might need to get that care from, to find that person, get an appointment, and show up. Once they show up to the person they think is correct based on what they think is going on, that person attends to that one complaint and maybe two other things that they know a lot about. And then they send them on their way. And they're done until they figure out they're sick with something else. This works really bad for people with multiple chronic illnesses. Most people with multiple chronic illnesses have a couple of behavioral health conditions. People with serious mental illness mostly have a couple mental illnesses and usually 3 or 4 medical conditions. They usually take about 15 or 16 medications at a time and see about 16 to 20 different healthcare providers a year. And they're supposed to keep all this straight. These are people without clinical training. They don't know what the care guidelines are, what care to get for what when, and they're not trained healthcare administrators who know healthcare systems and have the wherewithal to keep track of all this stuff. In fact, most of them have deficits of memory, concentration, perseverance on task, and executive function, yet we expect them to understand 7 or 8 conditions, half of them behavioral, 16 medications, and keep track of the activities of 20 providers annually. And we're surprised when things go bad. This is not clever on our part, and we need to do things differently. That's what population health is basically about. I'll start with some definitions. The technical definition is the health of population is measured by as measured. So the first thing about population health is it starts with measurement. But it's not just health. It's also social, economic, physical environment, personal health practices, individual capacity and coping, human biology, childhood development. It sounds kind of like the psychosocial model, doesn't it? Psychosocial biomodel, writ large, in population. And finally, the services you do as the last thing affecting population health. I tend to think of it as an administrator more as a conceptual framework for thinking about why some populations are healthier than others, as well as the policy development, research agenda, and resource allocation that flow from it. You know, we need to think about who's doing well and who isn't. To know who's doing well and who isn't, we need to measure it, just like impact does. And then we need to reallocate. At the end of the day, we need to change how and what we do things. Too often we think the way to innovate in a system is by getting other people to change. I found the only way I've ever innovated anything is by getting myself to change first. Population health is important in the U.S. because we're not very good at it. We are superb, bar none, at emergency crisis care. When you're dreadfully ill and need organs swapped around with other people, we are the place to come to. When you are chronically ill with a little hypertension, a little diabetes, and need some preventive care, we stink. Here's our rankings as done by the Association of State and Territorial Health Officers. Population health is about getting better, which means it's about healthcare provider organizations viewing themselves as the public health entity for the populations they serve. This is a big demand. How can you think and hold yourself accountable for the general health of the people you see for a particular specialty? That's what we're doing with the CMHCs in Missouri. So the factors that affect health, the biggest ones are socioeconomic factors. And it's tough to make a difference as healthcare providers, but we can. Long-lasting protective interventions have more impact than our clinical interventions. And the sad thing is that the research on patient education and counseling shows that it's not really very effective. That's very disappointing. I still try to educate my patients, but I was sobered when I saw that research. Population health is about achieving the triple aim as put out by the Institute for Health Improvement, better health for the population, along with better care for individuals, so we're still about individual care. And both of those together lead to lower cost through improvement. In Missouri, we figured, we've always thought that if we get the care better, the costs will take care of themselves, particularly if we focus more on underutilization than on overutilization. This is an important distinction. Most of what managed care organizations do is utilization management, not care management. Utilization management focuses on overutilization of expensive things that you try to do less of. Care management, by and large, focuses on underutilization of cheap things that you ought to be doing but aren't. Important distinction between utilization management and traditional managed care and care management. Population health management divides people up into a continuum. There's the healthy people that you address through health promotion, workplace wellness, health risk assessment to figure out early on who's at risk. Once you have people at risk, you apply methods like care coordination, physician collaborations. As people move into chronic illness, you're using more care coordination methods, and I'll give you some details on those. So in any setting, to population health management, PHM, there's four key things. You assess the individual so you can get population aggregates. You stratify your populations into subgroups. There are people that are high risk or high cost, and within them there are people that are actionable and not actionable. You can identify people that are very high cost but have conditions that are not actionable. You can't do anything about it. That's not very helpful. So it's important both to look at the risks in a stratification, but also whether there are concrete, immediate things you can do about that. You implement solutions, and then you measure what happened, and then you start again. Reporting is important. Transparently showing each other what you're doing has been a key to our success in Missouri. When we do data runs, we treat them all as rough initial runs, and we show our data to everybody. When people criticize our data, we thank them for the criticism and ask them how they would reanalyze it. Then we reanalyze it and show it to them again. It becomes a motivational hook to drag them deeper into the question. We find that showing data early actually doesn't cause problems. It improves relationships because then you argue about what the data means rather than unfortunate ways your organization treated each other in the past several years. So I would urge you to do transparent benchmarking and identify the individuals being benchmarked. Don't be so sensitive. You know, if you benchmark enough things, everybody will be at the top of something and everybody will be at the bottom of something. The other thing is particularly helpful with physicians because we're all exquisitely trained to be responsible to rankings. We wouldn't have got where we are if we weren't responsive to rankings. The best way to change physician behavior is to do a ranking of who's doing well or bad and put it in the break room with a thumbtack on the bulletin board with the names so everybody can see it. It's really, you know, these individual report cards, people, if you need that kind of kid gloves, you really need to get a little tougher and grow up. The principles of population management is population-based care. It's not about getting everybody perfect. It's about getting people in specific subgroups 50% better. You're thinking like a public health department. It's data-driven care. It's evidence-based care. You know, a lot of times when I talk with our psychiatric colleagues, they remind me that medicine is an art. I say it certainly is, but there's too many Jackson Pollocks. We need a couple more Rembrandts around instead of just slinging this stuff around. Let's have a little evidence and targeting. It is patient-centered, particularly in that it addresses the social determinants of health. This is a big stretch for primary care. You know, in behavioral health, we've been into social determinants of health for decades. Housing, social networks, getting community resources. We're doing health homes in our primary care, and this was the steep learning curve for them. The steep learning curve for us on behavioral health side was doing evidence-based care and using data. Primary care, that's more part of their culture. They're fine with checklists. They welcome checklists. They don't find them insulting. Team care, big thing, and that's also been a new finding in primary care that's newer for them than for us. And we're all working on integration. And there's a lot of ways to do integration. So in population-based care, we don't rely on the patients to know when they need, what they need, and who to ask. And we don't focus on fixing all the care gaps one patient at a time. You choose high-prevalence, actionable care gaps. Let me give you an example. In our health home operation in Missouri, one of the things we started out at was looking at asthma. It's actually one of the major causes of ER use and hospitalization among people with serious mental illness. They were actually getting more ER visits from asthma than they were from behavioral health reasons because they all smoke about 75% of them. So we went through and we looked for everybody that had a claim for asthma, and then we analyzed our pharmacy claims to look for anybody that didn't have a claim for inhaled corticosteroids, which you should take, of course, to prevent you from wheezing. That got aggregated into to-do lists that went out to the individual health homes. Each of them has a health home director that organizes the nurse care managers. So the message is, here's 25 people that need to be on, or that the primary care needs to consider if they should be on an inhaled corticosteroid. Please decide who gets them there. Can this patient go themselves? This other needs a mental health support worker to take them. Does the doctor need to call ahead of time? But get them to primary care, ask if they need that corticosteroid. We looked at one other gap. So the first gap is people who aren't getting any. The second gap is we looked at our pharmacy claims and said, who's getting it but not filling it every month? Who has a medication possession ratio of less than 0.8 for their inhaled corticosteroid? Then the to-do list goes out. We aggregate the list of patients. Let's talk to the patient. Why aren't you filling this? Why aren't you using it? Using this method, we were able to drive the percentage of people with seriously mentally ill people in CMHCs with asthma who were not regularly using an inhaled corticosteroid down by 45%. It works. It took about 2 quarters to do that. But we only did one thing at a time. We didn't give them 20 different things to do. We said, we're just going to try this one thing first. So one lesson is to be incremental so you can stay focused. Get one or two things done and then move on to the next thing. In that 45%, we certainly saw the drop in ER admissions, we thought, but we also saw on average that population, because we follow polypharmacy, and they dropped one med beyond, instead of adding a med, they dropped a med. And the med they dropped on average as a population was a psych med. So somehow putting people on a regular inhaled corticosteroid dropped their utilization of psych meds. Why would that be? Come on, your residents, why would that be? If you don't use your inhaled corticosteroid, you tend to overuse your Alupent inhaler. They had high fill rates for rescue inhalers. When you huff on that more than 4 to 6 times a day, you can't sleep, you're nervous and jittery. And then what do you ask people for? Benzos during the day and sleepers at night. That's interesting. This is the kind of interconnectivity you find when you can affect multiple things but it was the focus of just one population, one or two gaps. We didn't go for the whole asthma protocol. And we ask our clinics, our CMHCs, to think of them as the public health agency for their clinical population. About the preventive care, it's about the whole person. They're not responsible for doing all that, just like you're not responsible for getting people housing. You're responsible for referring them, assisting them. You're not supposed to build houses and buy apartment buildings. You're supposed to work with the people to get them to that resource. The same thing with their medical care needs. You're not responsible for doing their primary care, but you are responsible for making every reasonable effort you can to make sure they get it and stay plugged into it and follow up with it. Data-driven care is done with a couple of tools. Patient registries. These are lists of patients with particular conditions you've decided that you want to take a look at and the particular care gaps you want to try and reduce. I mentioned risk stratification already, and performance benchmarking and data sharing. So population management selects from the whole population those with the most immediate risk and the most actionable care improvement opportunities. It aids in your planning how to care for the whole population, but it also lets your organization know what new organizations and programs you might want to add and what new education you might want to have for your staff and your patients, and it helps you do early identification of increasing clinical problems. You know, when we looked at diabetes, and we again have primary care health homes and CMHC health homes. The CMHC health homes, 30% of the people are diabetic compared to 15% of the people in primary care. There are more diabetics in community mental health centers than there are in primary care practices. Who should be doing diabetic education? Why'd you rob the bank? That's where the money was. You know, if you want to do diabetic education, to go where the diabetics are. Different uses for data. Aggregate reporting, I've talked a little about. Individual drill down to do care coordination. I'll talk more about one of our tools. I'll talk now about. So one thing we've done a little differently that I think more systems would profit from is most care coordination is done agency to agency rather than through the payer. And the interesting thing about us payers like Medicaid is we have more of everybody's information than any individual provider. I know everybody within a month. I know everybody that, you know, the patient has seen, the diagnosis, the provider, the procedures. The pharmacy claims we know within seconds. Pharmacy claims adjudicated in real time. Medicaid knows that the patient has the medication before the patient gets out the door. Yet, we don't usually push that information down to the providers. So a couple actions we've taken in Missouri is we put all our Medicaid claims on an electronic health record. You can log in and get a 3-year history of any of your individual patients, all their medications, all their diagnoses, the pharmacies they use, the providers they go to. We've been doing this since 2004 and have not had a single HIPAA complaint or violation. Over 10 years with no complaints, no problems. And every Medicaid provider can see anything that their patient got from any other Medicaid provider. We now push that same out as a care coordination document on our statewide HIE. So if you get on our State Health Information Network and pull out information, you will get the Medicaid diagnoses, the pharmacy claims. Actually, our pharmacy claims have gotten better because some docs said, well, that's not the diagnosis. And we said, well, that's what you coded it as because their staff was upcoding. You know, so it cleans up the data also. That same data is used to create summary reports that the care managers can take to new physicians. So it's about being willing to share data. Being willing to share data. It's also about telling your story. We use a lot of our data to tell our story, which builds public support and builds understanding for thinking in this way. Also, data helps us do better planning and understanding, and actually, as I mentioned, improves interagency relationships, because then we can argue about what the data means as opposed to what each other did poorly with each other previously. Some important principles: use the data you have before collecting more. Show as much data as you can to as many partners as often as you can. Sunshine improves data quality. They may actually use it to make better decisions, and it's better to debate data than speculate anecdotes. When we show each other data, instead of saying what it means, we usually ask each other what they think it means. And treating all criticisms that the results are inaccurate or misleading as testable hypotheses. Okay, how do you think we should analyze it? Let's analyze it that way and meet again. Ooh, now we're really using data. Now we're asking questions and answering them. It's important to tell your data people that you want the quick, easy data runs first. It's often possible to get 80% of your request in 1 week. If you want it exactly run the way you want it, it'll usually take much longer. Rough results fast are usually more useful than slow results 6 months later. We treat all data runs as initial rough results. Important questions, we use more than one analytic approach. We like to use several medium data analytic vendors so we can check them against each other, both for accuracy. And if somebody has all your data and all your money, they can do what they want with you. So it's good to split up your data just as a way to keep cross-check and control on the program. And transparent benchmarking improves intention and increases involvement. At least when people are insulted and angry, at least they're involved with running the program. Most important principles using data is that perfect is the enemy of good, and you should act incrementally. Don't overplan. I see many agencies and states that fail because they focus too much on comprehensive planning and they never get started. It's better to apologize for a failed prompt attempt than to apologize for a missed opportunity. We apologize to each other often in Missouri. That's because we move rapidly. Planning. Much work remains to be done before we can announce our total failure to make any progress. Who's been on an initiative like that? Yeah, kind of exhausting. So back to population health management. That was on uses of data. I tend to think of it as 6 core services. This is also the way the Fed divides it up for the health home definitions, but it's useful for population health management in general. I've talked about care management. Care coordination is sharing data about what care the person's getting across multiple providers. It's important to focus on transitions of care, inpatient to outpatient. That's where we usually end up with poor care and misunderstanding. Most of us don't pay good attention when we're being discharged from the hospital. We don't read the 20 sheets, about 2/3 of which are boilerplate from our legal departments that are indecipherable and unhelpful anyway. If you want somebody to remember something going home from the hospital, give them 1 page. But our lawyers keep on making us give them 20 pages, and then they read nothing. So it's important to follow up with people promptly. Health promotion is getting preventive services. Referral individual family support is what you've all been doing at CMHCs for ages. It's new in primary care. And referral to community services is not about healthcare services. It's about housing, transportation, food, all that stuff CMHCs have been doing that's also relatively new for primary care. I gave the example on comprehensive care management. The way we're doing it on the CMHC side is a lot of it's based on administrative claims, but our CMHCs are all required to do metabolic monitoring. They have to get weight, blood pressure, hemoglobin A1C, LDLs, HDLs from everybody at least annually. We are at 88% completion. 88% of our people, we have complete data sets within the past 12 months. So now you can build a HEDIS indicator. You have a diagnosis of diabetes off the claim, you have a hemoglobin A1C off your lab clinical values, and you can start to build a couple of key HEDIS indicators and use that as a disease registry. I mentioned in the ASMAX example how we then push that information out to nurse care managers who work with the organization to decide who will act on it. Care coordination is coordinating between multiple providers, implementing the care plan, planning discharges, scheduling, communicating with the collateral healthcare providers. I want to talk a little about HIPAA. HIPAA is routinely overinterpreted. By the way, does your state have laws stricter than the federal HIPAA regulation? Do you go beyond HIPAA, or is your state laws no further than HIPAA? Do you know?
We're about the same.
You're about the same.
A little more strict.
Okay. So most organizations overinterpret and overdo HIPAA. They interpret it more restrictive than necessary. HIPAA allows you to share information for treatment, payment, and operations. Treatment includes coordination or management of health care. It includes all these care coordination, care management activities when they're implemented with an individual patient. It includes consultation. It includes referral. It even includes related services. You do not need authorization to disclose personal health information. HIPAA explicitly says you do not need a patient's consent to release personal health information for the purposes of treatment. You don't have to. You don't have to ask for consent for the Fed. Treatment is broadly defined and includes related services. It's not just healthcare services. It is services related to a healthcare condition. If somebody is in disability housing and they would not have that housing if they didn't have a medical condition, disability housing is a related service. So things like rehab services, disability housing. The federal regs explicitly say that HHS believes that disclosures for treatment are appropriate for timely quality treatment. They argue in favor of it. The following, when undertaken for single consumer or treatment services, case coordination, care management, all this health home population management stuff is viewed as treatment under HIPAA, and you are allowed to exchange information absent information. The most surprising truth is you can even exchange information over the patient's objections. HIPAA allows you, and there's the citation, 45 CFR 164.522. If your HIPAA officers are nervous, ask them to show you where it says you can't, and then you show them where it says it can. Many people that do training on HIPAA have never read the federal regulation. They just have a slide set. And they mostly train on what you can't do. They don't train on what you can do. If you're in an organization and your HIPAA training is mostly in what you can't do, you need a new HIPAA presentation. You need a HIPAA presentation that focuses on what you can do. You can share information over patient objection unless you've adopted a policy to follow patient objection. A word about liability. Well, what about liability? I always ask. Let's do a poll first. How many of you have been in this field working in healthcare for 1 to 10 years? 10 to 20. 20 to 30. 30 to 40. I'm one of those, yeah. So in this room, it looks to me, added up real quick, about 600 years of healthcare experience. How many of you have ever had a sanction for a HIPAA violation for treatment? Really? How many of you individually know a colleague that actually had a HIPAA sanction for a violation for treatment? How many of you know somebody's been hit by a car? How many of you know somebody's been hit by lightning? Yeah. You're more likely to get hit by lightning than you are to have a HIPAA violation. Your fears are delusional. Your fears are delusional. I mean, look at the evidence. So we talk about liability. Liability is the job not of the general counsel. General counsels give legal advice. They do not give court orders. Too many CEOs act like their general counsel legal advice is a court order. CEOs have to balance multiple liabilities. They have financial liabilities, clinical liabilities, legal liabilities, but they also have public relation and operational. CEOs need to be more serious about their other liabilities and not be delusional about the level of risk. They are incorrectly assessing their risks. So why does behavioral health need population management? Well, accountable care organization is requiring a lot more of it to happen. Seriously mentally ill people are sicker and need it a lot more. Population management needs behavioral health to succeed, and the psychiatrist shortage makes it difficult for us to meet the need out there without resorting to population health methods. We will never see everybody individually in 15 to 30-minute visits. Healthcare reform has increased demand for healthcare services by increasing coverage. Stigma is down. The ACA requires community health needs assessment. It requires expansion of prevention and wellness. It requires accountable care organizations to do population health management, patient-centered homes. I'm going to give you the Missouri example of health homes for people with chronic conditions. These are all population health management initiatives funded and or mandated by the ACA. So it's a growing thing. It's going to be part of your practice. You need to get good at it. Or you can learn to enjoy being bad at it. That's the alternative. So what do providers need? You need to know how to do care coordination or how to work with your organization so your organization can do it. You need to understand how care management occurs and how you can participate. And you need to be comfortable with clinical integration. We've talked about transparency, data, and technology already. The other reason we need it is our people don't live long. People with no mental disorder live to their late 70s. People with any mental disorder in the general population live to their mid-60s. People with Medicare, Medicaid disability live to their mid-50s. Live to their mid-50s. This is a life expectancy on a par with sub-Saharan Africa. It's a shorter life expectancy than somebody newly diagnosed with HIV. This is an epidemic. This is a health disparities population. Remember the Katie study, designed to compare antipsychotics? They also gathered a lot of metabolic data. For those of you not familiar, metabolic syndrome is having 3 out of 5 conditions, being overweight, here measured by waist, having dyslipidemia, here measured by high triglycerides, low levels of protective good cholesterol, having high blood pressure, and having diabetes. If you have 3 out of 5, you have metabolic syndrome. People with metabolic syndrome have the same risk of having a heart attack in the next 10 years as somebody that has already had a heart attack. People with metabolic syndrome have the same risk of having a heart attack as somebody that's already had a heart attack. These are serious risk factors. CATIE are people with schizophrenia that went to clinics that could do national level studies, multi-center. The NHANES is a national survey done by the CDC every 3 to 5 years. So NHANES is the general U.S. population. CATIE is people with schizophrenia that go to university clinics like your own. So 1 in 3 men with schizophrenia had metabolic syndrome in CATIE compared to 1 in 5. Women half did. If you meet a woman with schizophrenia, you should assume she has metabolic syndrome until proven otherwise. That should be your base clinic assumption going into the room. 1 in 4 otherwise. And look at the rates of dyslipidemia, running around 50%. Look at the rates of hypertension, running around 50%. Diabetes, 14 to 21%. Much higher than the general population. More shockingly, at baseline, that 50% with dyslipidemia, 88% were not being treated. Of the 50% with hypertension, almost 2/3 were not being treated. And of the 14 to 20% with diabetes, almost 1/3 was not being treated. In university clinics that can do multinational center research, they're unable to detect and treat hypertension and diabetes in people they're doing research on. We should be ashamed. So it's no surprise they're dying. Contributing factors are smoking and obesity, very high rates in our population, inactivity, polypharmacy, they get a lot of meds and it's not all helpful. Underdiagnosis of medical conditions is huge, and inadequate treatment of medical conditions is huge in the populations we serve. This also leads to some very high costs. This is work done by Milliman. People with no mental disorder and commercial insurance cost about $375 per member per month, and Medicaid just under $600, Medicare and Medicaid $400. Medicare and Medicaid are bimodal populations. They include both the elderly and the disabled in Medicare, and the low-income women and children and the disabled in Medicaid. So these are an average of a bimodal population. If you add in the people that have a mental disorder, the costs triple. So I became Medicaid director about 2 years ago now. I went to my first national Medicaid director in May of 2014. We went around the room. This was 5 months after Medicaid expanded, 5 months after the eligibility rules changed, 5 months after everybody had to institute new computer systems to handle this all and expand Medicaid and change eligibility. The question was to the Medicaid directors in the room, what do you most want to talk to your colleagues about at this meeting? 2/3 said behavioral health. Could have knocked me out of the chair. I was the only behavioral health guy in the year. 2/3 of the Medicaid directors wanted to talk about behavioral health. You think you know why? Where's the money going? What's driving their spend? Here's what it looks like in New York State, a fabulously expensive Medicaid program. No mental health disorder in New York is about $16,000 annually. The physical health care costs alone for people with substance use and mental health disorders are about $5,000, $6,000 more than that. And their behavioral health costs are about another $5,000 or $6,000. The increased medical costs are as much as the total behavioral health costs. Seen the same spending pattern in multiple different programs. So, I'm going to tell a story first for our mission. Our mission is recovery, right, for persons with serious mental illness. I'm going to tell you about Victoria. Victoria is a woman I treated for about 8-9 years. When I first met Victoria, she would call me up at all hours of the day or night, agitated, manic, intoxicated, planning on cutting herself, had cut on herself, was going to commit suicide, didn't know where she was. 2 runs through substance abuse treatment got her off the meth. She did a little better. It became apparent she had rapid cycling bipolar. That's pretty easy to treat. That was 3 months. Struggled with her alcohol dependence, intermittent binge drinking for about 18 months after that, but she did really good on substance abuse treatment. About 3 more runs through treatment and she was largely under control of her alcohol. And then we spent 4 years working on her severe PTSD from the trauma, sexual and physical abuse she had had from a young girl through the last, just before she started treatment, when men were victimizing her on the streets repeatedly. That took about 4 or 5 years. So at the end of about 8 years, and Victoria's in stable housing, going to community college, has decent friends that are supportive, hasn't been hospitalized, great mental status, social, and she drops dead. She drops dead of a large clot that came out of her leg that was so big that it occluded the inferior vena cava umbrella we had put in to catch the clot she was sprinkling up to her lungs. She was 300 pounds. She smoked 3 packs a day. She was inactive. She was taking massive amounts of steroid for her cigarette-induced asthma. We had won all the behavioral health battles. Victoria had achieved behavioral health recovery when she dropped dead. So our problem, our mission is recovery. Our problem is early death from physical illness prevents recovery. Learn that in medical school. Once they drop dead of a heart attack, their schizophrenia does not improve. So I wanted to do something different in Missouri. I don't want outcomes like that. She worked hard, and she didn't get to enjoy the fruits of her labor because we didn't intend to this other stuff. So stupidity, quitters never win and winners never quit, but those who never win and never quit are idiots. This is to suggest that we need to change, because systems don't change until we change. It's about changing yourself first. There's no magic bullet. Integration helps some. Team care helps some. Population management helps some. Healthcare delivery based on deep partnerships. It's really, in the end, how well we can work with each other, how good we are at being externally oriented, how good we are about helping the other entity achieve its goals and mission, instead of saying, that's just mine. I'm busy enough. You go away now. So what's a health home? It's not a Medicaid benefit. It's not just a program or team. It's a different way of doing business. It's a different way of using data. It's a different way of delivering a care. And it's a different way of relating within your organization and externally with the other organizations around you. Our 4 strategies are coordination of care. I mentioned our EHR. Cyber Access is the name of the portal. You can look at one patient. PROAC is an aggregation tool. You can look at many patients. We pursue a lot of co-location. We actually give grants for CMHCs and FQHCs to co-locate. We've gone from 2 organizations that were a CMHC and an FQHC up to about 9. We have our CMHCs doing medical disease management for people with mental illness because they see them most frequently. And we have retooled our psychosocial rehab programs to do more than recreation, housekeeping, and appropriate social behavior. They now also do interventions around obesity, smoking, and physical activity. The payments for the health homes, HH's health homes, are paid per member per month. The CMHCs get $80 per member per month. The FQHCs, federally qualified health centers, get $60 per member per month. It is not, they don't get it for everybody. Everybody's eligible, but we auto-enrolled high utilizers. So what's different about our program than most is we're not doing everybody. We're doing the high utilizers of the 6s. We auto-enroll people that cost more than $10,000 that did not have terminal conditions. So we took out people with end-stage renal disease, with high-level oncology disorders. We focused on people that needed a lot done and had things that were actionable. We did not let the provider, the practice did not get to select. The payer selected. Because how would you know who a high utilizer is? You don't know all the other care they're getting. How could you? And since we auto-enroll, then you have a known number of people. You're getting your $80 per member per month on day 1, so you can hire your staff immediately because you know you have your cash flow immediately. People can opt out. Only about 1.2% did. It was negligible, the opt-out rate. The service needs were identified by the health history and status, not by provider referral. The outcomes are measured by groups of people, not by individuals. We do not like HEDIS indicators, which are narrow disease state indicators that have too many rule-outs. They have low denominators. They have low denominators in them. Why would I only be interested in your LDL after you get heart disease or diabetes? Why shouldn't I take care of your LDL first? It's a leading indicator. HEDIS indicators are done by NCQA, which is the creature of the insurance industry, just like Joint Commission is the creature of the Hospital Association. They are designed to be useful to that provider group and not to population health and management. They are good disease indicators, but if you want to do population management, they are inadequate for your purpose. We do HEDIS indicators because they're the coin of the realm. Everybody wants to see them. We're just underimpressed with their utility. Our strategy is care coordination and facilitation of health care. We add all the CMHCs added primary care nurse managers. They had to be primary care nurses because our CMHCs already knew a lot about psychiatric care. We didn't need more psychiatric nurses. There's one for every 200 people, nurse care manager. As I said, we've instituted disease management programs, no smoking, diabetic management. We do preventive screenings. Everybody gets metabolic screenings. We believe that health technology should be used to support the service system. In particular, payer data should be available for clinicians to use for clinical management. We believe care coordination is best provided by a local community-based provider where there's a face-to-face relationship. For that reason, the community mental health support workers have the most frequent and longest duration relationships. Therefore, they have the most opportunity. So this was about using data to decide what issue they should talk about, using nurse care managers to educate and target how they talk about that. It is about a dose-response curve of a personal relationship. How often do I have to meet with you for how long to change your behavior? The CMHCs, as I will show you, outperform the primary care practices. They did this for two reasons. The people in the CMHCs were sicker, so there was more improvement to be had. Second, the primary care practices did their patient intervention primarily by RNs, about 15 minutes once every 2 months. The CMHCs did it by community support worker, targeted and educated by RNs, and they were able to deliver an hour and a half to 2 hours of interaction 2 to 3 times a month. A dose-response curve that's data-targeted and evidence-based. That's what makes this stuff work. The primary care health homes got behavioral health consultants, and the CMHC health homes got primary care consultants. Primary care love this. Usually they use consultants. They don't get to be consultants. This is kind of a different role for them in life. So what's different? Treatment as usual, individual practitioners, episodic care as I described earlier, focusing on the presenting problem, referring out for other needs. In managed care, they mostly manage access to care and utilization management. And managed care companies traditionally do not attempt to change how you do your business and help you be a better organization. They do not send in practice coaches. They do not help you with your workflows, that kind of thing. Health homes, it's about changing your basic way to practice. If you wanted to be a health home in Missouri, you understood going in that you were making a commitment to change how you work, not just to do this one contract. Change is not about a contract and contract compliance. Health homes are integrative care, they're continuous care, coordinate across the system, data-driven management, and you change the way you practice. We sent in practice coaches, we added nurse care managers. We actually tracked whether or not they hired the staff we insist on. If they didn't hire the staff, we took back the money. We tracked if they used the HIT tool. Since our care management tool is a centralized tool on a website, we know who opened what page how often. If you couldn't be coordinating care if you didn't open and look at the care coordination tools. So if you weren't opening the web pages and looking at them, then we held back some money. If you couldn't make your staffing pattern, we couldn't enroll any more people till you met it. We actively managed them. We didn't just do a contract and walk away from it. IT is cool. You can see what everybody's doing if you give everybody a web tool. You know? And we would send a management report. So if you're a CMHC and I'm paying you because you're not using care coordination, I'm going to send you a report, and everybody authorized to log in, you're going to see how often that individual employee looked at how many patients and which pages. So now you have a management tool to say, hey, you two come to my office. You know, why aren't you looking at this thing? Because I'm getting in trouble. So it's about the payer giving management tools to the providers that we're paying for, because it's in my interest. I want you to use that information, so I should give it to you. I want you to act on that information, so I should package it up so it's easy and quick. Eligibility in primary care was diabetes or having 2 of the 6 conditions listed. Notice these conditions are very low bars, using tobacco and being overweight, not even being obese. In CMHCs, everybody was eligible. Basically, it was either having a serious mental illness or any other behavioral health condition plus being overweight or smoking. So if I could find one person that was skinny, didn't smoke, and didn't have any substance use or mental illness, then they would not be eligible. But we only auto-enroll the people that cost more than $10,000. So it's a hot spot. It's about targeting. It's about maintaining focus. We are statewide. We do not believe in demonstration projects. They mostly demonstrate a lack of commitment. If you really believed it, you'd go do it. You know, Cortez did not conquer Mexico as a demonstration project. He did not land his boats, take a village for a day or two, go back to Spain and write journal articles. He burned his boats on the shore and swept everything before him. He insisted on change. If you want to implement, go ahead and implement. All the FQHCs are in, all the CMHCs are in. Actually, enrollment's up to about 22,000 on the CMHC side, about 19,000 on the primary care side. We've done another expansion, but it is a hotspot program. Here's the team: nurse care manager for every 250 patients, care coordinator for every 500 patients. That's an associate degree person that assists the nurse, referrals, inputting data, faxing stuff, making referrals. Health home director, usually a nurse, primary care behavioral health consultant in the primary care setting, primary care physician consultant in the CMHC setting. They got some practice coaching. Oh, the two other fun IT things we did, and this is incremental again. We don't do this on one big computer system. We stand up one thing cheap and dumb at a time. So another thing I get as a provider is you all have to call me up for initial authorization of stay. If somebody gets admitted, your hospital has to call and say, they got pneumonia. Okay, you get 2 days, click. Payer knows before the doctor that the patient's in the hospital. Payer should push that back down to the doctors. We sort out all the inpatient authorization of stay at midnight, send it in a flat file over to the health home analytic group. It gets dumped in a complicated, expensive computer program called an Access database. Dumb, simple, cheap. It sorts it out by health home, does an automated email. You can get access to do automated emails out to each, so each health home gets a list. Here's everybody who got admitted yesterday. The second cool thing we found, how many of you remember 9/11? Remember the anthrax scare afterwards? Fed set up syndromic surveillance where ERs all have to send in a constant feed of everybody that comes to the ER. If you go to the ER with a broken arm, within an hour your State Department of Health will get a little note of who you are, your age and demographics, and the fact that you're in there with a acute complaint of a broken arm. Your State Department of Health knows everybody in the ER before any of the providers do. Do they share it? Is that dumb? Could we be better? Could we do better? I shouldn't say dumb. I said my wife tries to get me to be kind. Yeah. So we get a file from our Department of Mental Health sorted in the Access database, and at midnight all the health homes get an email of everybody that was in the ER the day before. It's how can I as a payer, how can I as government push this information out? Read the federal regs carefully. We're allowed to do this. It just takes the willpower and the willingness to risk. If you want to change, you have to trust each other, and you have to be willing to take risks together. That's more important than data and rates and staffing patterns. Same 6 functions I showed you before are the ones required by CMS. Actually, hospital MOUs proved to be a dry hole. We sent a joint letter to the Hospital Association from MoHealthNet, the Medicaid agency, wanted them to have agreements. The agreement went to the hospital lawyers, it went to the CMHC lawyers, and they're still talking about it. They are hypothesizing possible legal liability things that may happen at some hypothetical future, and they cannot come to agreement until the other entity agrees to assume all reliability for anything that might happen, including ISIS attacks. I don't know. So we gave up on MOUs, and we decided to focus on the CMHC health home director taking the social work director out to lunch. That works a lot better. A lot better. They start calling each other back shop. We failed to rein in our lawyers from stopping us from doing stuff. The best thing to do is to do stuff and then tell the lawyer when they need to defend you, but not tell them what they're going to do ahead of time. And certainly never ask their permission. That's very bad. You should always tell them what you're going to do and say, now get ready on defending me and figure out how to mitigate my risks. Do not ask them what you can do. Because the safest thing is to stay home under the bed, and nobody will ever sue you. You only get in trouble if you want to actually deliver care, God forbid. I told you about the authorization of stay data. I told you health homes are expected to see everybody within 72 hours of discharge. Running out of time, so I'm going to go on to our outcomes. The good news here is that small changes make a huge difference in things like dyslipidemia, blood pressure, and hemoglobin A1C. Here's our outcomes on metabolic screening. When we started in February 2012, we had data on 12%. We are up now. In March, we had 86%. We're up to 89% compliance on having blood pressures, weights, and the labs I mentioned. It's about to-do lists. Who haven't you got it yet? I need those. It's about changing culture. In primary care, how many of you, the last time you went and saw your primary care doc, said, gee, I don't know if you want to do it, but could I have some blood? It might be kind of good for you. That's how we do it in CMHCs. We had to retrain to say, give me your arm, we're going to get some blood. It's the care you need. Now we're going to do it. Just getting very factual, like your primary care doc does. Hemoglobin A1Cs. 7% of people as a population had uncontrolled hemoglobin A1Cs in general. Their ag population average was 10%. 1 year later, they were down to 9% at the CMHCs. The year after that, they're down at 8.85, about a 1.5% hemoglobin A1C drop. According to the Framingham studies, a 1-point drop will lead to a 21% reduction in diabetes-related deaths, 14% reduction in heart attacks, 31% reduction in kidney failure, blindness, and neuropathy, the microvascular complications. Of the people that were under control, they crept up about 0.1%. So we maintained good control on the people that were under control and brought under control to a substantial portion. This is a population average. This is not HEDIS. This is a population health measurement, not a HEDIS indicator. Notice also that the CMHCs were sicker to begin with and healthier at the end of the day. They outperformed primary care for the reasons I mentioned. LDL levels, 45% had uncontrolled LDL levels at population aggregate. Not too bad, actually, 130. Got it down by 15 points the first year, another 4 points the second year. A 10% drop, and we got about a 20% drop here. Gives a decrease over 10 years of 30% reduction in cardiovascular disease. CMHCs, again, outperform primary care. Blood pressure changes over time. Oh, in the LDL group, we didn't hold the line as well. Of those that were under control, we had about a 7-point creep in LDLs. We did not do as well. Blood pressure, about a quarter had uncontrolled hypertension. Population average of 144/90, dropping to 131/82. About a 20-point drop. 6-point drop gives you a 16% reduction in cardiovascular disease, 42% reduction in stroke, according to Framingham studies. Small changes make a big difference to populations over time. This is what it means to think like a public health entity, to think in terms of population health management. This is what a mental health agency can do if it puts its mind to it and is willing to change. Here's the traditional HEDIS indicators. HDL, good cholesterol for clients with cardiovascular disease. 34% increase in people that have it measured and under control. Two parts to the, we didn't accept it if it wasn't measured. HEDIS says it doesn't count. If you don't measure it, we're not going to count it. It counts the same as being out of control. So we're about at the, we're up from 21% to 55%. Nice increase on HEDIS hypertension measure, 24% up to 65% compliance. A couple more HEDIS indicators just showing that when you use these methods, you can improve your performance over time. It's the same thing you do in the impact model. You measure something. If it doesn't get better, you go back and look at it again. You assign specific individuals to act at it, then you measure it again. Hospital follow-up. So the big low-hanging fruit, one of them has been hospital follow-up. We expect them to see everybody within 72 hours of discharge. The top line is people seen within 72 hours of discharge. The bottom line is those who also got medication reconciliation, where their medications were reviewed by one of the RNs to make sure they understood the changes and had what they needed, up from 30% to 70%. This has had the result of reducing hospitalizations. In the baseline year, about 35% of people had one hospitalization. By year 3, we're down to under 20% of people with a hospitalization in the third year. Primary care started lower. They had nice increases too. Hospital days per 1,000 member months. This is all hospital days, both behavioral health and medical. About 80% of the days are medical. Only about 20% of the days are behavioral health. I would point you out the turquoise line. Pre is 4 years before we began the program. Pre-3 is 3 years. Pre-2 is 2 years. Pre-1 is the prior year. Post-1 is the first year past. So you see a nice drop. You see a rising trend. Then a drop from 250 days per 1,000 member months down to about 160 days per 1,000 member months. Decreased total hospital utilization. ER visits down about 35%. Same thing, pre-3 is 3 years pre, 1 post is 1 year post. Healthcare savings. Everybody wants to see the savings. This looks at savings for people after 18 months in the program, whether they came in the first year or the second year or the third year, how much better was it after 18 months? 20,000 people served by the CMHC health homes. Cost of care was $80 per member per month. They earned back the $80 and saved another $98. Aggregate cost reduction, $31 million. 50% of this savings is due from people moving from Medicare to from Medicaid to Medicare. About half is true reduction of utilization. but about half is cost shift from the state to the Fed. But I work for the state, so this is how I'm judged. Fed wants to hire me, I'll work for them. Primary care didn't do as well, in part because they auto-enrolled down to $2,600. They acted more like a person-centered medical home and took people that were much less sick to fill their dance card. Here's a policy choice. Do you want to save a lot of money, which means you focus just on a few very expensive people, or do you want to improve the care for a whole lot of people, which means you don't save as much money because you're eating up your savings providing care to people that were cheap to begin with? This is a policy decision. We did it one way for one group, the other way for the other group. We'll probably change it next year. We're just fiddling around trying to figure out what to do next. So what made it possible? I've talked about data analytics, sharing information, but what really makes it possible was a relationship of trust between the Department of Mental Health, the Medicaid office, the State Budget Office, the CMHC Trade Association, and the Primary Care Trade Association. Transparently sharing data, not being willing to take the risk that we would be criticized, willing to take the risk that it was somehow a violation of privacy or bad things of mysterious nature would happen. We were all willing to take risk and tolerate it. You know, it's really not about our anxiety, it's about getting people better. We used a lot of principled motivational interviewing. We used motivational interviewing on each other, not just on the patients. And I would recommend to you all read Getting to Yes by Uri and Fishy. I'll say that again. Getting to Yes by Uri, U-R-Y, and Fisher. Negotiation. It's great clinically. It's great administratively. I use it with my wife and children. It's good stuff. And it's quick reading. It's much quicker than most of the stuff you read. Dysfunction. The only consistent feature in all of your dissatisfying relationships is you. If a partnership is not going well, it's you that needs to change. First, you know, we approach partnership poorly in behavioral health for people that have been trained in psychology. We usually approach potential partners by telling them how unrespected we are, how unloved we are, how we never get any resources and no one cares about our stuff, and then we ask them for some of their resources. That's pretty unattractive. This is ineffective for partnering. I actually researched partnership as an undergraduate in college. I would go to drinking establishments, identify potential partners with attractive resources, explain to them, much like we do in behavioral health, how needy I felt and how I wasn't getting any resources. I went home alone all the time. With Medicaid, I listened to them first. I told them they had really interesting problems I wanted to hear more about, and I gave them little gifts of administrative and political nature. And I helped them, and I helped them, and I helped them, and now I'm the director. So, if you want a partner, don't talk about your needs first, ask about their needs. Don't expect to get something, give something first. Don't limit your assistance to the project at hand, assist them wherever you can. Don't make it about the immediate deal, make it about the next 10 deals and about the next 20 years. Almost everybody you partner with as an entity, your organization and their organization will be in that community after you both retire. You can either have a good marriage or you can have a bad marriage, but you can't annul and you can't divorce because nobody's going anywhere. Those are your choices. Don't push a specific position, pursue a common interest, talk about the interests. Don't withhold information, reveal everything helpful, and most of all, be loyal. If your partner's getting beat up and you can step up and protect them, do it. If the newspaper's saying they're lousy, explain how they're wonderful. If they're taking a budget hit and you can move a little money around and bear the cost, then give them a little juice. That's the way you get a partner, is you show loyalty. So we talk a lot. We talk not just about data, we talk about how we're going to act with each other. We talk about the nature of our long-term partnership as much as we talk about the current deal before us. We talk straight, we're respectful, we're transparent, we admit we're wrong, we try to show loyalty. We don't always achieve this, but these are our values. We try to listen first, keep our commitments, so we can trust each other more and more. You know, in general, organizations that are autonomous and invulnerable behave badly. So we try to build deals that make us interdependently vulnerable. We actively make ourselves vulnerable to each other to align our interests. The way we funded the health homes, of that $80, $3 has to get paid to the Coalition of Community Mental Health Centers, the trade association, for technical assistance, training, and data analytics. They get to keep $1. They hire staff to help manage the program. $2 gets paid to a university for the same thing, state university. That state university hires the state staff that works in the state offices administering the program and hires more and runs more of the IT contracts. So now we have the CMHC members who are forced by the state to give additional money to their trade organization. So now the trade organization has resources that they wouldn't have that their members must give them. I am essentially a member and she is managing her members on my behalf. CMHCs are getting lots of money they wouldn't get otherwise. The state, I get staff I wouldn't get otherwise and IT systems I wouldn't get otherwise that do not appear on the state budget and cannot be taken from me by the legislature. Nobody can walk away without hurting themselves. CMHCs can't walk away without losing their 80. Their association can't walk away without losing their staff. I can't walk away without losing my staff. We all have IT systems that help us lobby better. We have made ourselves more vulnerably independent, and we are more powerful than ever. It's counterintuitive. It's about changing how you do business as much as it is about clinical guidelines and data. So, change. When the winds of change blow hard enough, the most trivial things can turn into deadly projectiles. Where do you want to be in the picture? You want to be the thing hit by the projectile? If you're just sitting there not doing anything? Often you might feel like the projectile being blown around on the initiative of the day. If you're willing to change yourself, if you're willing to trust and to take risk, you can be the wind. And you can drive everything before you. Thank you.